Hello and welcome to the Symposium on Healthcare Value Analysis and Infection Prevention. I'm Kelly Pyrek, editor and publisher of Healthcare Hygiene magazine. I invite you to explore with us the key issues that these two disciplines can address in a challenging healthcare landscape. We've gathered thought leaders from across the country to share their expertise with you, and we hope you'll find the sessions to be a springboard for further dialogue at your institution. No important undertaking like this symposium is conducted alone. We appreciate our incredible speakers for their hard work in preparing their presentations. We also thank our partners in this endeavor, the Association for Healthcare Value Analysis Professionals, AVAP, the Pierce Foundation for Scientific Endeavor, and the Environmental Services Optimization Playbook, ESOP. We also acknowledge generous underwriting from Cintas Corporation, which made this program possible. As a reminder, this symposium will be available on demand for 90 days in case you miss any portion of the program. If you have any questions, please email me at kelly@healthcarehygienemagazine.com. Thank you for your participation, and please stay tuned for more symposia to come this year.
Good afternoon, everyone. Kelly and I are thrilled to have the opportunity to talk with you a little bit about infection prevention and value analysis collaboration, an opportunity to deliver value. It's really something that Kelly and I have learned and have worked together quite a bit over the last couple of years, and it's become readily apparent to us that that collaboration has really borne fruit in our professional lives, and certainly hope that you gain some usable information by the end of today. So our objectives for today, we hope that you will be able to discuss the importance of infection prevention and value analysis collaboration in your organizational decision-making, that you'll be able to describe how that infection prevention and value analysis collaboration might contribute. And we'll talk quite a lot about how it contributed to our organizational response to the global healthcare crisis that we are seemingly continuing to try and dig our way out of. And we do want to talk a little bit about the evolution of our value analysis program and that real need to maximize collaboration among value analysis, supply chain, infection prevention, et cetera, and really how that evolution really helped our organization continue to deliver safe care and quality outcomes amid the chaos which has been the last several years. So you might be asking yourself, who are these people? And so my name is Susan Miller. I've been a nurse for probably 112 years. Feels that way at any rate. And I am the Senior Director for Enterprise Value Analysis for Jefferson Health in Philadelphia. And my colleague, Kelly Zabriskie, will introduce herself.
Yep. Thank you, Susan. So again, my name is Kelly Zabriskie, and I am the Enterprise Vice President for Infection Prevention for Jefferson Health. I began my career as an infection preventionist in 2004. So I've been in this role for in an infection prevention role for a while. I worked for Jefferson for 6 years. And prior to that, I spent the majority of my time working for the Barnabas Health System hospitals in New Jersey. I've had the opportunity to be the Philadelphia Delaware Valley APIC president, and I currently get the opportunity to serve as the legislative chapter representative. I'm also fortunate enough to be on the board for the HLAC, the Healthcare Laundry Accreditation Council, and I sit on the Pennsylvania Patient Safety HAI Advisory Board. So it's a wonderful career, and I've really enjoyed the collaboration that we've had over the past several years. So thank you, Susan, for allowing me to introduce myself.
Thanks, Kelly. You know, it's been really fun for me to work with Kelly, but then also to have the opportunity to talk with all of you. That opportunity came about through Kelly Pyrek and Aaron, and through the work that I've done with the Association of Healthcare Value Analysis Professionals. And so I've been fortunate enough to be president of that organization back in 2019. And so that's a little bit about who we are. Now you might say, well, who's Jefferson Health? And you know, you look at the slide here and you say, well, 14 hospitals, but that's actually not completely accurate. Jefferson Health is rapidly growing, still growing organization. If you spool back a little bit, 2015, we were a 3-hospital system, an academic medical center, a neuroscience hospital, and a small community hospital in South Philadelphia. Between mid 2015 and January of 2018, we went from 3 hospitals to 14. And as of last October, we have expanded yet again, merging with the Einstein Health System in Philadelphia, and the Jefferson Health System is now 18 hospitals in Philadelphia, in the suburbs, and in New Jersey. So why are we talking about this, and what are we talking about in terms of collaboration and value analysis? In 2017, our value analysis program at Jefferson just encompassed our academic medical center at the neuroscience hospital and the small community hospital in South Philadelphia. We were on the cusp of building our enterprise value analysis program. We were in the middle of integrating our supply chain division across the enterprise. And we were really asking ourselves, how do we become best in class? And what is it that we've learned over the years of value analysis? Where do we have opportunities to improve? And one of the things that we talked about quite a bit and that we realized was that until 2017, when we needed help from our colleagues in infection prevention, it would be an ad hoc request. Oh, we have a request for an anti-infective ventriculostomy catheter. Well, what are our, ventriculitis rates anyway? And what we learned from our colleagues in infection prevention, and let's be honest, also from a few other departments, was that we really needed to expand our scope of our enterprise value analysis representation. And so as we built our enterprise committees encompassing folks from every division, we also said one of the most important caveats of that was that we needed to have an infection preventionist on every one of our subcommittees, because we knew that there were things that we maybe were missing, or we had an opportunity to focus on in a little bit of a different way. So today we're going to talk a little bit about some of that early collaboration and how that collaboration specifically prepared us to be able to weather 2020 and beyond, and really set the stage for us to grow and develop in our organization. So what are the key components of our enterprise value analysis program? I think it was a very difficult journey initially, but really and truly what we focus on within our program is enterprise-wide approach to decision-making. We want to support transparency and collaboration, and we want to standardize and support product evaluation and variation reduction. This was a tough concept for individual organizations who were used to making value analysis decisions on their own, but it was really a critical piece of our enterprise development because it set the stage for what we were able to do next. Another key component is our ability to have data-driven decision-making. We really rely very specifically on evidence-based research, the device safety information. We're extremely fortunate that we have enabling technology that integrates all of that into our workflow and into our request management system. And so it's really a seamless opportunity for us to look at a request, to say, what's the evidence that supports that request? What's the device safety information? When was it cleared by the FDA? Have there been recalls? Have there been adverse events? And really enables us to make some sound decisions about where are we today and where are we going to go into the future. And then finally, to foster clinical engagement. We really wanted to maximize the physicians and other clinicians' engagement in value analysis. And again, looking at utilization of the relevant evidence and device safety information. I get excited when I look at our current statistics because we have a group of physicians that are in our enabling technology, looking at the evidence regularly every month. I marvel at their ability to be in the middle of looking at what's all the safety information about the devices that are being considered. And so that has really helped us as we've moved along in our program. Oh, excuse me for going the wrong direction here. Our program really is one in which patient safety and quality outcomes supported by objective evidence are really the primary factors in our decision making. And this really sets the stage for then how do we make decisions? Who's involved in those decisions? How does that help us then? And how has that helped us over the last year or two? So all entities, that means no one gets to opt out. So all of our divisions are in. All requests are in for new or modified consumable or disposable products that are utilized in patient care or the protection of staff while delivering that care. All of our committees are chaired by a physician or a clinical leader and a nursing vice president. And we have a process whereby the enterprise service line leaders review and endorse every single end user request before we start to work on it. This has really helped us to weed out those one-off requests from an individual physician who gets a great idea at 2:30 in the morning and thinks, oh, I'll put in a value analysis request for that. So it's really helped us to focus our efforts. And then just a couple of other points about our program. Obviously, there are going to be urgent clinical needs, and we have a process to allow an individual use of a device or a product should that be needed, and a formal appeals process if someone is unhappy with a decision. One just sort of comment there, if there is someone wants to file an appeal of a value analysis decision, they have to bring forward new data or evidence that was not available when we made our original decision. It just can't be based on the fact that, gee, I don't like what you decided about my request. So our value analysis structure is one in which we have a value analysis steering committee, which is chaired by one of our chief medical officers. We have physician vice chairs, one from each division on that steering committee, as well as every chief nursing officer in our enterprise sits as part of that steering committee. And then our committee chairs and others that are needed to support that. And we'll talk a little bit about how we have changed and enhanced the infection prevention role in the steering committee. We'll talk about that a little bit later on in our presentation. We do have 5 committees now. We're excited that we are launching our clinical lab value analysis committee actually this week. Clinical lab requests used to come through one of our other committees, and we really, over the past couple of years, have realized that there's an urgent need to pull all of the clinical lab issues into one committee. And so we are moving forward with that. And if you see the boxes here on your right-hand side, these are the other processes within Jefferson with whom we integrate as the need arises. So that would be through IS&T, our information systems, pharmacy and therapeutics, the capital committee, and one that we have consistently been working with. It's been a great collaboration, the Jefferson Clinical Research Institute. So all IRB studies come through value analysis, at least for our knowledge. We don't weigh in on whether or not the study should be done, but rather we want and need to be involved with understanding what are the devices that are in use in our organization. The last thing any of us want to do is to learn about a device that is in use in our organization when we see it on the 11 o'clock news. And so that's been a really great collaboration for us. So we've had some early experiences that have really led to some closer collaboration. Kelly, I'm going to turn it over to you to talk a bit about when we got started and what some of those early experiences helped us to learn and to move forward with.
Thanks, Susan. So again, as Susan mentioned, each of those committees that she talked about, there is an infection prevention director from one of our divisions on those committees. So early on, infection control has been actively involved in a lot of the input that's gathered early in the value analysis process. We've established this because we wanted to make sure that we didn't find out later that there was something that infection prevention had a concern about, maybe the way something was cleaned or disposed of, or it actually created some additional issues for us. So having infection prevention in on these the discussions early has really helped us to make sure that things are done appropriately, and that, again, like Susan said, nobody wants to be surprised about something later on. So one of the things we learned about early on is standardization of products. It's very important we reduce the variation in practices based on collaboration between the clinical community, infection prevention, and value analysis. Standardizing practice and products helped us to ensure that we were all obviously utilizing the same piece of equipment or the same product, so that we could make sure everyone was doing the same thing. So that if we had concerns or we saw any issues, we weren't going back and looking through different products and trying to understand what someone was doing. So this has really helped us to ensure truly best practices being done, because we have a group of people making decisions, looking in on the products and trying to establish what is the best item that we should be using. One of the early things that we talked about or that came up was the back table covers for the OR, for the cases, to cover the cases. This came up and we talked about, well, which product should we be utilizing? How should we be utilizing this? And this was really one of the first things that we did in our committee to standardize this. And again, it goes through one of those 5 categories that Susan brought up, and the IP director that's on that committee will bring this up and talk about it and bring it back to the divisional level, and then the enterprise level, so everybody can comment in on it. So the IP that sits on these divisions are the ones speaking for the IPs across the enterprise. And so this is one of the examples where we talked about it and how could we best, what type of table cover could we use that would help keep the instruments on the back table sterile, which will reduce any risk for infections, and how could we get input from everyone? And IPs were obviously very a big piece of that, making that decision. Next slide.
Yep.
So again, the early part of this is, the early learning, the value of how we coordinate this together was one of the things that came up that really brought this home is when we have supply interruptions. And this helped to reinforce the value of collaboration. We had challenges requiring coordinated efforts among infection prevention, value analysis, clinicians, and supply chain across the enterprise. It causes multifactorial. There could be natural disasters, plant closures, national back orders in sold or dual source categories. And what this did is really allowed open communication. It allowed us to work together to operationalize getting substitutions and ensuring that they meet the intent from an IP perspective, and to eliminate or alleviate any concerns with risk of increasing infections. When you see these interruptions that come up, it could be for things, we give 2 examples here, CHG bathing products, as a few of you may remember a few years ago, and it's been over the last couple of years, we've seen a few of these CHG bathing issues that have come up, or CHG products in general that have come up, as well as oral care products. And right away when you see these, you have to respond quickly to be able to, number one, get the products you need in, and number 2, make sure that they're doing the intent of what you need. And having this relationship with your value analysis and your supply chain, it allowed us to coordinate quickly to look at products. We were able to quickly pivot where we needed to pull in products and get them in, because we had a system to analyze what was out there and have a direct voice in saying, okay, we need to pivot on this oral care product because, you know, they're saying that it's not available anymore. And what else can we use that will be as effective, do the job it needs to do? We have to do education to the staff when we bring this in. So having that clinical piece there as well, having infection control to say, yes, it still meets that intent, really all worked well. Susan, I don't know if you had any other points for this slide as well, because this is a big, a big coordination with us.
Yeah, and I think one of the things that this period did, and this really happened primarily in 2019, some of you may remember what seemed like terrible supply interruptions. We had no idea what was coming next, but there were some very challenging supply interruptions. But I think that what this whole process in the beginning of our enterprise work did was it helped there to be trust established across the enterprise. Folks worked together. They saw the value of collaboration. There weren't 4 individual independent divisions out there trying to solve these problems on their own. Everyone was working together to say, okay, if we're going to set prioritization, how can we make that consistent across the enterprise? If we have scarce resources, well, what do you have today? What are the cases that you have coming up tomorrow? And how can we share products? How can I give you a case of something that you need and you give me a case of something that I need? And this early learning was truly valuable when we looked at what was to come, because people trusted one another. And that was a huge piece. The other piece was that we were able to point to clear and specific improvement in patient outcomes so that staff saw that it wasn't simply about a financial decision. So Kelly, you want to talk about our CAUTI project?
Yeah, I do want to emphasize, Susan, that's a really good point, or 2 points you made, is trust, and that, again, to your point, we were doing this for certain standardization. And again, that leads us right into one of our early successes is the impact this had with CAUTI. So early on, we realized that there were some changes to reporting inclusions and reduced the value-based purchasing targets for CAUTI. As you may be aware, this is one of the metrics that we do follow, and we're looking at our benchmarks and our healthcare acquired infections. We did notice that this was an opportunity that we had to help us attain goals. And when we looked at this, we realized that enterprise-wide, we had some opportunities. We utilized the Medical Surgical Commodities and Devices Value Analysis Committee. And we went back and started looking at what are some of the things that we could standardize? What was everyone utilizing? This was an opportunity to look at the types of Foley catheter kits and the catheter care products that we were utilizing, and looking at what is the best option. The evidence-based research. What should we be utilizing? And we were able to bring in together infection prevention and the value analysis team to look at this and to say, okay, we're using multiple Foley catheter kits across the enterprise, and what is the best option to standardize our process? Again, and even though price is not the option here, it also is a plus when you can utilize one larger, you're getting a large volume of product done. So we're reducing a cost. Hopefully we're utilizing the best kit that we can utilize, and which will hopefully ultimately reduce our CAUTIs, which is again a reduction in cost, because again, we're reducing infections. We're also hopefully getting, with value-based purchasing, if you meet certain benchmarks, you do get monies potentially. There's other programs too that you reduce penalties. So analyzing all this and pulling this all together really is an important piece with value analysis, with infection control, with clinical. So again, we looked at the kits that we were using. We were looking at the products across the enterprise and how we can roll this out to reduce our variation in products and establish protocols that we could all utilize because we were using the same products. So that is one piece that we did. And then it also led us to looking at the, as it were listed here, the criteria for use of externalized female urinary containment devices as well, that we were able to standardize. Again, having this committee and the relationship together, we could utilize the group to look at these different products. We could do trials at each of the hospitals. So it really helped us, to look at where we were going. And then again, it helped us to improve our outcomes. We did see that we trended downwards with our numbers by utilizing certain processes and equipment. And again, here we noticed overall 28% reduction in CAUTIs from 2018 to 2020, which is great as well, because some of that with 2020, there was obviously COVID, which did impact things, but we did keep aligned. And, again, as we noticed, as we were able to keep our products that we needed, our device days were, we associated reduction in device days from standardizing criteria for patient selection and increasing utilization of external urinary containment devices in female patients. That was a big piece as well. These external urinary containment devices really helped us with a lot of our patients. And again, we were able to standardize this over time into all of our divisional hospitals, which was a very big help. And again, by keeping the IPs involved with supply chain, we had a good relationship on if there were any issues or concerns. We had a voice, which was helpful. Reduction in device-related HAPIs in male patients at the academic medical center after formulary changes and external catheters as well. And these are all, like Susan mentioned early on, the improving of outcomes, which is another, big, important piece when you're looking at bringing these groups together in practice. Having us all together on these individual value analysis committees really helps the conversation as well, because each person can bring something up and add to the conversation and help us get to a good point. The CAUTI piece is one of our, is a big initiative, and as we'll see later on too as well, it continues to happen as products go on back order and so forth. So this was one of our bigger initiatives. So I will transition into one of my favorite topics that I do really, I think is one of the biggest successes for our team, is unfortunately what happened in 2020 with the onslaught of COVID. As you know, this was one of our biggest issues, but I truly believe that our relationship with value analysis and supply chain, the relationship as Susan mentioned, the trust that we had before really truly set us up in a good position for what was coming in 2020 and beyond. So next slide. So again, here the established relationship really supported our decision making during a global health crisis. And I do feel that our previous relationship allowed us to quickly establish a process when we had to pivot to certain different things with PPE. As you know, during this time, we had rapid changing environment when it came to PPE, and things were no longer available. And by establishing what we had in place before, we had an open communication system right away between infection control and supply chain and value analysis. I do think we were extremely successful in keeping the amount of supplies needed on hand because we already had a process to vet things. We ended up having weekly meetings with infection control, myself and one of the other leaders in value analysis and supply chain, so that we could talk about, we set par levels, we looked at our PPE. Mostly this is around PPE initially, about where we needed to go. And having this, we were able to vet products. I can remember actually going to someone's house to pick up a piece of a PPE to look at. It was a gown, to see, can we look at this? And this allowed us to talk through situations and have really almost daily calls sometimes about gloves, gowns, N95s, surgical masks. And then we, brought into disinfectants and hand sanitizer. But we talked all the time about what was allowed and what we needed to do to get the best products in here. One of the second bullet is setting the minimum safety requirement for scarce products, enhanced clinical validation of equivalency, and promoted bedside caregiver confidence. And that is huge. We worked really hard together to make sure that the products we brought in were vetted. We actually went to one agency to check on the gowns that we were bringing in, because if anyone remembers, there was some questionable labeling on things that came in from China around, could this be used for the medical community? And we actually had them tested to ensure that they were actually resistant and didn't allow fluids to get through. And I consider this one of the biggest, successes of how we work together. And it allowed our healthcare workers to truly feel that we had their best interest, because they knew infection control was involved, as well as supply chain. And we made sure we vetted, everything that we utilized. We did our best not to compromise any of our standards. And everything we brought in went across the enterprise. So we brought in products that we knew we could give to every single division and hospital to make sure that they had a standard. And we put out a lot of, broadcast messaging to support this. We did town halls when we needed to talk about the type of equipment we had, and policies. And this all worked again together. Infection control and supply chain and value analysis were truly tied at the hip during COVID. And again, I think what we did truly allowed us to be successful. Susan, I don't know if you have anything to add. This is one of my topics that I could keep talking about for a long time.
That's all right, Kelly. I think you hit the points. I think, though, the most important, not the most important, but certainly one of the important pieces is that this really enabled us to set a consistent approach to the way that we were going to vet things. So while there was a lot happening and there was a lot changing and there were products coming and products going and a lot of change, that we really felt as though we had a consistent process that then enabled us to make the best possible decisions under the circumstances. So we really wanted to take the approach of keeping the patient and the healthcare worker at the center of our decision making, and then all of the collaboration that had to happen among the clinical community, infection prevention, value analysis, and supply chain really helped us to consistently then, and in a way that it was not a fire drill, if you will.
Correct. Yes.
To really have a consistent process. So Kelly, you were sort of right in the middle of that. You want to talk a little bit about that?
Yeah, I think what you mentioned is really important, is that we truly tried not to react like it was a fire drill. We tried very hard to be proactive. So we kept, again, par level. So when we met and discussed, we looked weekly at where we were with certain levels to see, okay, we're getting to that point. We need to make sure that we have new product coming in. I think really what Susan talked about is not having a fire drill, by keeping this standard of process, by looking at things. And also value analysis, our supply chain reported out on our weekly COVID huddles to talk about products that were coming in or any shortages that we had. So we really integrated everybody into these types of conversations, and that helped us, to be successful, and to everyone to be understanding that infection prevention has approved this, supply chain is getting in these products. And we had an established process that we communicated across the board to everyone, so that, everyone felt supported and felt protected. Again, even down to the disinfectants, we looked at different disinfectants that were coming in. And then, of course, there was a whole bunch of other clinical products that we needed to evaluate as well that did utilize the same process. Just initially, a lot of these shortages were around, PPE and hand sanitizer and so forth.
Right. But there was even a lot of conversation with the OR when patients needed surgery, and there were some new requirements coming out from the medical community around smoke evacuation, and how can the clinicians in the OR be safe. And so there was really just a constantly changing narrative that we we're sort of just moving our way through. But the fact that we had a process and that we could with confidence say to our staff, we have vetted products, we are confident that you will be protected, I think is one of the most important pieces of the puzzle. One of the things I wanted to share is one of the tools that we use to really enhance our clinician confidence. Anybody who's worked for any amount of time in a hospital knows that there are certain products that staff are very possessive about. And one of them, at least in our organization and probably in many organizations, is exam gloves. Everybody, you know, these are our gloves. These are the kind of gloves that we use. We use these gloves. Well, if you all remember, one of the most constrained categories was that of gloves. You know, 80% of the world's gloves come through Malaysia. And when Malaysia had a plant shut down and a COVID outbreak, then there were many issues related to gloves. And so one of the things that we did is that we built a matrix. And this is a piece of that matrix that you can see. And we lined up all of the glove options that we had vetted. And part of what we had at the bottom of this chart also for the staff were actual pictures of what did the glove box look like. So when they saw a box of gloves in their clinical area, they would know that it had been vetted, it was on the matrix, and then we went through and identified where could those gloves be used. And there were certain gloves that could be used by EVS and certain gloves that couldn't, and same with chemo. And so really, but again, it was just to reassure the clinicians who were dealing with so much on the front lines that we really wanted to be able to put tools in their hands that made them confident that what they were using to care for their patients was going to protect them. So we made our way through 2020, and we thought as we got to 21 and we were hearing about vaccines that perhaps things were going to improve. And then we had the perfect storm of 2021 and 2022. When we're still struggling with how many ships are sitting outside of a port, and what are the raw material shortages, and what are the plant closures that have happened. And so the constant change in products and in availability that we thought would improve as we got past the initial crisis actually has continued and is likely to be continuing through at least the remainder of 2022 with, again, constantly changing products and shortages and so forth. So the new reality that we have been dealing with and reacting to and planning for has been around that new reality of we have lots and lots of supply interruptions. We have back orders, we have discontinuations, we have recalls. And so again, having a consistent process by which back orders are managed in the organization so that we don't have 14 hospitals or 18 hospitals, each individually trying to address issues on their own, has really enabled us to be able to pivot and to maximize the products that we're putting in our clinicians' hands. That being said, we've also had a slightly different role because we've been at the cutting edge of some of this. And Kelly, maybe you can talk a little bit about the issue identification challenges that we've had.
Sure. So I will say a little bit. We've had a couple processes where we had to act very quickly on getting some new products in because of recalls. That has been one of the bigger issues that we've come across recently. We had an ultrasound gel recall that I think we responded to so quickly from because we've had a process in place and we had a communication process in place that once this was identified, and honestly, Jefferson was one of the initial places to identify this, we were able to quickly identify that there was some concerns with an ultrasound gel, have it turned around, pulled off of our shelves across our enterprise and get a new product in, I believe it was within 48 hours, we're on the phone with everyone. Supply chain was working their wonders and getting in a new product as soon as possible and getting it out on the shelves and really taking away any of these risks so quickly. And it was, again, I truly believe that this was from the communications that we've had in place, and especially escalated during COVID, that we were able to see this rapid turnaround occur. We've had a couple, I believe there was a mouthwash recall we had. And these types of issues really, came about, or the corrective actions came about because we had a process in place. And again, people trusted us. When we reached out and said we have an issue, we reached out to supply chain. We were on the phone. They were doing what they needed to do, looked at their supplies, brought in a product. We could all vet it. We talked amongst ourselves. Infection preventionists had a great relationship with their supply chain locally as well to turn this around. And I think that's the important piece that I always like to stress, that, we work at an enterprise level and down to the divisional level, and each of the infection prevention directors worked with their supply chain leadership to get these products in place for us as soon as possible. So once we identify these things, it's the way we cascade everything through, has been very, very successful. And we're able to turn things around relatively quickly.
That being said, I think that one of the things that keeps me up at night a little bit is that I'm continue to be very concerned about the number and the breadth of substitute products which we have in our clinicians' hands even to this day. And we really do keep top of mind, not only can we get something in the hands of the clinicians, but what is it that we're putting in the hands of the clinicians? And we've been through all of the roller coaster ride of the various product categories, but it's not sufficient to just say we are going to get safety needles and syringes, because then it became even more important that we vetted, well, what is the safety mechanism that is that we're putting in the clinician's hands? Because it's not simply can we get another device with a safety mechanism, but how does that safety mechanism function? And is it consistent enough with the product that they're familiar with that we're not going to create additional risk because the safety mechanism functions completely differently? And I will say our clinicians have been wonderful at being flexible and going with the flow with the various products that we have put on their shelves. And we've said, we can't get you needle and syringe combos, but we'll get you the components. We can't get you the product A that you're used to, but we'll get you the components of that. And or guess what? Your custom packs are coming in without certain components. You're going to have to add them. And our clinical teams have done yeoman's work at being able to be flexible and to cope with that. But it, in all candor, it does keep me up at night. I do worry about what we are putting the stress that we're adding to our clinical teams because of the chaos of the marketplace and the variety of products that we have put in front of them. I think the other thing that has come front and center in the last year or so for us, and Kelly and I have talked a lot about it, and we've been partners in investigating, is that when we start to see product failures, if we see a product failure, then trying to do a root cause analysis and understand what was the product that failed. Was it one of our substitute products? That's concerning enough. I think the thing that scared me the most was that we had a product that had been constrained for many, many months, 8 or 9 months, while the whole um, the product was retooled and completely remanufactured. And then we started to see product failures when the new version of that product came back into the marketplace. And so that gave me pause to think about, well, what is it about the new product that it may be contributing to these failures? And is there something innately that's a challenge around the raw materials, or is it an education issue? Do we have to re-educate our staff? Staff are so cued into visual cues that if we can't get the PCA tubing that they're used to with the blue stripe, and we're going to provide them with the tubing with no stripe, we're taking away those visual cues that add to the safety of the product. And so it is a time in which mitigating risk is really top of mind. And it's something that I'm concerned about as we move forward. So Kelly, I don't know if you want to talk about some of the subs that we've brought in, but I think, you've had discussions about some of the subs and even the cleaning products and the time to effectiveness and that kind of thing.
Yeah, I mean, that's another piece to this that we look at as well, that has, I think, been a big piece for infection control to be involved with is, as you know, we see a lot more. It's really important to make sure how you're cleaning some of these products and pieces of equipment. And that's something that infection control has really been, trying to be a part of and try to keep that in the forefront, because we do, as we see more products coming in and different pieces of products, and they require different types of cleaning, which potentially may inhibit some of the, the turnaround time, and how do we get to utilize this, and can it still be utilized effectively? So there's a lot of different things that do come into play in regards to when you have a substitute product or even new products coming in, and how do they look at it? And again, for us, one of the important things that we do is when we bring in these substitute products, it's important for us to evaluate if we start to see, like Susan mentioned, infections or any changes that we're starting to look at. One of the first things that we look at from infection control is we reach out is, when did this product come into play? Did it change anything? Is it providing the same function that the substitute, the previous product was doing? So, that this is the new reality is definitely there because of these substitute products coming in.
Yep. So this is sort of an eye chart, but we have built quite a few tools to support the clinician's decision making. There was a product shortage in one category, and so we really had to get very specific around depending upon what is the procedure that you're doing. And these were the options that you had initially in the second column for the product that you were using. These are the options you have in the third column for at this point. And then, are you needing to drop the item on a sterile field, or are you not? Some can, some can't, and so forth. So again, this is just an example of some of the tools that we've built to support the clinicians as we go forward. So then as we look to what does the future hold, I think, everything that we're doing is sort of continues to be a work in progress. The organization has seen fit, and I think well-deserved, to ask Kelly to assume an enterprise-wide role as the Vice President of Infection Prevention. And so that really gave us the opportunity, that and looking through at the past couple of years and what our collaboration has done for the organization. So one of the things that we've done as a developmental step has been to add an infection prevention role to our value analysis steering committee, and Kelly's joined that committee as the Vice President for Enterprise Infection Prevention. And that's really been a huge help to me and to all of us on the steering committee as we try to navigate sort of this new reality. And then the other thing that I'm going to let Kelly talk a little bit about is we have so many challenges that are presented by equipment cleaning, and not, everybody's got a grand idea about what new piece of equipment they'd like to bring in, but the downstream effect, not only of that equipment and the consumables that go along with that, but then how are they going to be cleaned is really critical. So Kelly, do you want to talk a little bit about that?
Sure, I'll just give I started to talk a little bit about that before, but yes, the cleaning piece is really huge. And anybody that knows, when you have any type of agencies coming through or they're doing any evaluations, how you clean a product is extremely important. And you have to go with the instructions for use. And a lot of these, products coming in, they might have some very different types of wipes you need to use, or you might need to send them through reprocessing or sterilization. And that can truly impact the use of the product, the turnaround time, or how that clinician needs to use that piece of equipment. So we've really started to focus on this. We found that people bring things in and they're not really they're not aware of how it's cleaned. So we're trying to really standardize this to make sure anything brought in that is being reused, we're aware of the cleaning implications and what does that look like, and is it something we can accomplish? Because if you can't, then truly it doesn't work in how you're handling this product.
And I think, just sort of as a final comment, I think because of the challenges that we've been facing, because of the downstream effect of the changes in the marketplace and the consolidation and product discontinuations and all of that, we've really had to take a hard look at much of what we're using. And Kelly and I have talked a bit about the fact that we're not always 100% comfortable with the choices that we're considering. And we wish that we had different options on the plate, but we don't. And so we're really out there trying to make the best possible decision under the circumstances. But we know that if we were in a perfect world, we would have the product that staff were familiar with and comfortable with and have that in abundant supply, but that's not the reality. And so really that critical thinking around how are we going to make the best decision that we can under the circumstances has been really top of mind for us. So as we sort of wrap this up a little bit this afternoon, or I think that we wanted to just go back and sort of talk about some of the lessons learned. What did we learn through all of this? I really can't emphasize enough that the early successes that we had, the lessons that we learned early on in the enterprise work and the collaboration paid dividends for us well into the future, and really helped us to navigate through the past couple of years. The fact that we had collaborative relationships established, I knew where Kelly's team was coming from, Kelly's team knew where our team was coming from, and it really enabled us to make quick, solid decisions based on the best available information at the time. The fact that we had done work in the beginning, reducing variation, then when we had supply challenges, if we had already reduced the variation in products, then we were able to roll those out in a much more clear way. And so that really smoothed the path for our future collaboration. And I go back to one of the early comments that I made, the fact that we were able to, among the IP, supply chain, value analysis, and clinical teams, establish trust among one another and enhance clinician confidence that we were really making the best possible decisions that we could. They were in the best interest of everybody. It's a lesson that we've learned. It's a lesson that in our organization, I think some other departments are learning and have learned, but it's something that doesn't always come easy. But really that early trust established really paved the way for the future. You know, just that sort of ending thought that our future decisions might not be comfortable, and they may still be the best decisions that we can make. Kelly, your thoughts about other lessons that we've learned?
No, I think I agree with you, Susan. I think that that really you summed it up very well, and that I think, again, just the relationship and the trust is the biggest piece to me, that we provide confidence to our clinicians with the decisions that we're making.
All right. So thank you for listening to us.
To earn your contact hour of nursing continuing education associated with this session, you will need to take and pass the 10-question true-false test with a grade of 90% or better. To get started, click on or copy and paste the URL into your internet browser to be taken to our CE portal. You will be asked to register, and then you will be directed to the test. If you pass, you will be able to view, download, and save your certificate. If you do not pass, you will have a total of 5 attempts to retake the test. You may store and share your grades and certificates for all sessions in the portal and access them by using the unique links provided at the end of each presentation. If you have any questions, please email me at kelly@healthcarehygienemagazine.com. Thank you, Susan and Kelly, for a terrific presentation. We are now going to open up our Q&A with the presenters. While we're waiting for our attendees to submit their questions via the chat function, why don't we start off by talking about how an enterprise value analysis program could be scaled to a single hospital or maybe even a smaller system than Jefferson. Are there any differences in approach or concept?
Well, Kelly, thank you for asking that. It's really not about size or complexity when you talk about value analysis programs. It is about the process. It is about the concepts that underpin your decision making. So it really doesn't matter if you are a standalone hospital, a small system, a big system, or an enormous system that's so complex that there are multiple subgroups within that. It really is about understanding the concepts of value analysis and applying those consistently, and then understanding the concepts of collaboration and identifying who your partners are within your organization. Kelly, what do you think?
Yes, I agree, Susan. I mean, really, this can be done in any type of facility size-wise. The important part is engaging the right people and taking the time to discuss the process and making sure everybody understands how it can be rolled out and sticking with that process over time. And I think it's definitely something that can be done and really should be done in any size facility.
Terrific. So you both talked a little bit in your presentation about standardization, and we have a question here from an attendee about, can you provide another example other than the operating room of how the standardization process can and should work?
So I can tell you that we are currently working on standardizing a few things around our enterprise system, but one specifically that's really on our forefront is standardizing our surface disinfectant wipes. So this is something that we are working on. Each of our hospitals kind of has a different wipe that's being used for our surfaces to disinfect in between patient use. And really what we're looking at is what is the best optimal wipe that should be used, following your instructions for use. We all know that that's an important piece. So we started looking at what is the most likely to be called out on those instructions for use. So we are working at that. Now it's a process because again, each hospital has a different product, but we're trying to standardize that in order to keep things consistent and making sure that we can pull together, one type of product. Now, we do know that there may be alternatives that are needed, but we wanted to see how we can get one standard wipe across our system. Obviously, you'll need two, potentially one for a bleach product and then one a non-bleach product. But we are looking to standardize that. Susan, do you have any further?
Yeah, I think the other piece of it is it doesn't really even matter if it's one unit across multiple divisions. We've done a lot of work trying to standardize the care in our intensive care nurseries. So we have 3 of our 4 divisions that have intensive care nurseries. And so those are groups that up until recently have not really worked together, but really in looking at things like how are they taking care of CVC catheters in neonates? How are they managing infant bathing? How are they managing a variety of different care deliveries? And really spooling it back to what is the care we should be delivering to all sick babies across our enterprise? Not, this is the way I've always done it. Well, I've always done it this way, or I like this, or I like that, because we do get a lot of that. But it's really peeling it back to what is the care that we should be delivering. And if you sort of come together around that, then the standardization piece of it just sort of follows.
Yeah.
Terrific. We have another question here. What if it is challenging to get people to collaborate, to get out of their silos, to communicate, to make decisions together? Your system had quite an incredible journey. So what if folks are encountering some resistance in their own facilities?
Kelly, it's interesting that you mentioned that, because as Kelly Z and I put this presentation together, at least I was remembering the early days of our enterprise collaboration. And I will tell you, it was not easy. We really had a lot of pushback from various departments, divisions, et cetera. I'm special. I shouldn't need to be included, or this is the way that we've always delivered care. This is how we do it at this division. And so it's absolutely not easy, but it is about trying to find common ground. So if you spool back the questions to a place of agreement, can you agree? You may not agree with the approach to these products, but can you agree with the outcomes we are trying to drive toward? Then that sometimes helps. Kelly, I think you have some ideas or also around getting the individuals engaged a little bit in the process too.
So that's what I was going to say. I think part of it is, and again, to Susan's point, this isn't something that just happens overnight. It's taking the time and sticking with it. But it's definitely engaging the different partners from each of the facilities or hospitals or divisions. I think that's one thing that we were very successful with, is making sure that there was someone involved from every hospital division and making sure they were a part of it. So I think it's important ahead of time too, we try to engage those individuals. I know for the infection prevention part, we make sure that there's an infection preventionist from each division involved in the different subgroups that we have. And I think that's important, and having conversations around why we think this might be the direction that we want to go, or having that research. I think one of the things that's really successful is having the person coming to talk about why this product might be needed, and the background information, or on both parts, why we need to use it, or why we might not need to standardize this product or this particular product. But I think really when I think about this, it's the consistency and staying with it. Mm-hmm. It's really understanding that this is a good thing and keeping that conversation going and not giving up on it. Because I think, Susan, like you said, there were times that it could be difficult, but I think it's just sticking with it and knowing that it does work its way out eventually. But it's engaging the people is important.
Exactly. And I think it's also establishing trust.
Yes.
And I think we talked about this a little bit in our presentation, but tomorrow they can help another division. And so people get to understand that it's a whole lot easier to solve these problems together as a group rather than having, 4 individual groups of people going out after trying to solve the problem together. That being said, we still have pockets of folks in our organizations that don't quite get it and are reluctant to share what they have because they're afraid they may need it. And so we engage all of the resources that we have to try and have those conversations. So again, getting back to what Kelly was talking about, talking with people and communicating with them about what's the end game, what's the goal. So it really, it's an interactive process. There's no doubt about it.
Great answers, ladies. Appreciate that. So coming out of really an incredible supply crunch because of the pandemic, we have a question here. If a substitute product or products failed, is there any recourse for the institution? What do you think about that?
That's an interesting question, because one of the dilemmas that we face daily is the whole challenge around substitute products or implementing new products or such as that. And I think the overarching goal in all of that, of course, is mitigating risk and looking to really, when we vet substitutes, look at how much is this going to have to change the delivery of care at the bedside. That being said, one of the most difficult things I think for my team, and I'm sure for Kelly's team as well, is knowing when you're faced with an objection, what's at the root of it. And is it that this substitute product really clinically is not working, or is it that it's unfamiliar? And so when to drive toward consensus and standardization and to sort of go on ahead, and when to pause and to sort of uncover what might be at the root of it. And maybe there is a clinical objection that we need to pay attention to in these subs. Kelly, what comments do you have?
I agree. I think, there is a time when you as a team, you have to pull together and, like you said, look at things. And like you're saying, when there's different products that come in with shortages and you might have to utilize something, I think sometimes it's coming up with someone making that tough decision to say, this is the time we might need to pull back. And, you have to take all factors into place. And there are times when you need to do that. And it's not wrong to do that, but sometimes that decision has to be made when you start looking at the outcomes, or you look at it's not working as we intended. And that is something that does need to come back, especially with shortages or changing in a product, especially when you find out something is not available. As everybody knows, we're still seeing shortages with a lot of things right now. Obviously, contrast media and formula are the current ones that we're all trying to look at. How do we manage these things?
Yeah. I think the other piece of the puzzle there also is having a process and educating staff at the grassroots level that when they have a problem with a product, what do they do with that? How do they manage that? Trying to make sure that we have a trail. So through whatever your incident reporting system happens to be, to make sure that the staff nurse, I'm going to use that example, the staff nurse at the bedside knows that if she has a piece of IV tubing that's cracked, what does she do with that once she's dealt with the immediate problem with the patient? And so what we've tried to do is to educate our staff, and some of our staff are really wonderful at grabbing your camera or your phone and taking a picture of the product that's failed, taking a picture of the packaging. That's the other piece for us is we have so many subs. I need to understand that whether this is the original product, substitute A, substitute B, or substitute D. And then to get people to report that consistently, so that I might only have one problem in one division, but I might have another problem over at another one.
That is very helpful advice. Thank you. We have another question here. What do I do if my facility doesn't have a value analysis professional on staff, or I don't have a value analysis team, and I'm starting from scratch? How can I build my own program? What do you think?
So it's very interesting that you mentioned that, Kelly. This is my opportunity to be a little shameless and to really encourage folks to take advantage of the resources that are available on avap.org. ahvap.org is the National Association of Healthcare Value Analysis Professionals. We have quite a lot of resources that are available on our website. And then also, as a member, you have the availability of a huge resource library, other professionals. The goal of AVAP is education, networking, providing resources to healthcare value analysis professionals. Well, maybe your organization doesn't have one, but maybe you're the person that has responsibility for balancing the clinical and financial attributes of a given product or equipment decision. And so it really doesn't matter whether you have the title or you don't have the title in your organization. It's really around who's the individual that has that responsibility, and encouraging folks to fully take advantage of what AVAP has to offer in terms of mentoring and support and resources.
Susan, we can also, another group that we could work with is APIC. For anyone that's involved with infection control, that is our Association for the Professionals of Infection Control. We that's also a resource that can be used. And again, we align ourselves with giving the best options available and help to, a lot of information is there and a lot of standards around infection prevention. And we also work with all these, the other groups like you mentioned, to try to help standardize these different things. So that's another resource that can be utilized. And it's obviously, as an infection preventionist, it's helped me tremendously. And there's a lot of guidance and tools there that are there for people to use. So I would highly recommend, along with the other agencies that have been mentioned, is to please look and research APIC, APIC. They're available to you, and it's extremely helpful as well. So thank you.
Wonderful. It looks like those are the questions that we have at this time. So I will thank you both so much for sharing your insights, and we really do appreciate our attendees' questions. We will be making available a transcript of this conversation in the platform for download very soon. If there are additional questions from attendees, I would suggest that you send them to me, Kelly at healthcarehygienemagazine.com. This concludes our Q&A, and I just want to say thank you to everyone for your time and attention today, and we'll see you at the next session.
Thanks, Kelly.
That's a wrap for today's sessions. We hope you found them to be engaging and thought-provoking. We will make transcripts of the chat sessions available on demand shortly. And just as a reminder, if you missed any of today's program, you will be able to return to the event platform for the next 90 days.